So let's talk about that for a minute. So the first real dual inhibition that allowed, actually the drug got approved on this basis, HOPE, really was pertuzumab. So we have Neosphere, we have Triphenema, we have trials that really now have improved the pathologic complete response rate. So what's your feeling? Now we even have data that at least minimally, and we'll talk about this in a minute, minimally supports the idea that pathologic CR did result in an improved 5-year disease-free survival. So you want to talk a little bit about the long-term data from Neosphere?
Well, I think that, first of all, I think the FDA approving drugs based on pathologic complete response is a very unique situation. We have one drug that has accelerated approval and no others, and that drug happened to have already been approved based on very favorable toxicity and not only improved progression-free survival, but improved survival that was quite dramatic in the metastatic setting in the Cleopatra trial. So, I think that it's kind of a unique situation where you couldn't lose really from giving it, and it's such a limited exposure. You only give it in that time course, and certainly we give it in that time course in the adjuvant setting as well, based on that information. Looking at long-term results from neoadjuvant therapy is complicated. A lot of these trials, including Neosphere, gave anthracycline post-surgery. And I think that there is certainly the ability in HER2 positive and triple negative disease to overcome resistance to taxane-based therapy, and maybe even to some degree in HER2 positive disease to HER2 targeted therapy by giving an anthracycline. So you do change the disease-free survival assessment if you give chemo post-surgery, and that's been an issue, as well as the fact that neoadjuvant trials by design are not powered as a primary endpoint to look at disease-free survival. So I think that we definitely saw that giving trastuzumab versus not in the early trials like NOAA improved outcome. So that wasn't a question. Once we've gotten into already improved outcome and adding more drugs, it's been more complicated. And I think Neosphere is an example of that. It certainly didn't show no benefit, but the benefit was modest, and I think it's affected by what you give patients after surgery and by a number of other factors. So it doesn't really bother me that we don't see the huge differences, but I think it has taught us a lesson about what we should expect in terms of the long-term outcome from these neoadjuvant trials.
Right. I mean, one question really I think that has brought this into perspective, and I like to ask my European colleagues about this, is really NeoAlto. NeoAlto, in which lapatinib doubled the pathologic complete response rate when added to trastuzumab-based therapy, but really did not have a significant 5-year disease-free survival benefit. Michael, can you comment on that? I mean,
absolutely, yes. I have the impression that we have in the neoadjuvant area, and Hope was focusing exactly, she put the fingers a little bit in the wound, that we do some kind of 2 steps forward and 1 step back. So NeoAlto, number 1, was underpowered to see a survival benefit because this trial was designed to see a PAT-CR difference between the study arms, so either the trastuzumab arm or the lapatinib arm or the combination of trastuzumab and lapatinib. And number 2, one of the major, not problems, but design, which might explain then the outcome, is that the anthracycline portion of the chemotherapy was given after surgery, so which means that these patients have not received the optimal neoadjuvant chemo portion. And just giving a taxane with an anti-HER2 therapy or the double combination is a very nice hypothesis-generating trial, but to use the results of this trial to extrapolate for disease-free and overall survival is not the proper way. So the proper way is to do the optimal chemotherapy as the neoadjuvant backbone treatment with the addition of anti-HER2 therapy. And if the double combination is giving us better results for PCR, especially for HER2 positive disease, with a delta which is quite high, in the region of 10 to 20% between the study arm and the standard, makes me still feel positive that we are going to see positive result in disease-free and overall survival. So let's wait for Affinity trial next year, in which, in the adjuvant setting, the double combination trastuzumab-pertuzumab was done, and then we will see, is it going to be positive, or is it going to be positive maybe just in the patient with high risk, like node positive, because that study learned from ALTO that we should stop enrolling node-negative patients in which the 5-year overall survival with anthracycline, taxane, and trastuzumab is in the region of 95%. So how can you increase 95% to 100 and plus %? So that study, affinity was enriched in the patient population with node-positive disease. So let's wait for that one. But I think it was a clever and very intelligent and very good step for the patients to give a provisional approval for the double combination, trastuzumab, pertuzumab, in the neoadjuvant setting by FDA. And by the way, that was followed by the EMEA. And in Germany, because I'm the speaker of all German breast cancer centers, I did a survey, which is 2 months ago. So I would say 90% of us are using, if we treat patients with neoadjuvant therapy in HER2-positive disease, we're using double combination at the moment.
With pertuzumab.
With pertuzumab.
Okay. Ahmad, same thing in Brussels?
You know, the problem is not reimbursed in Belgium.
It isn't.
So, but if we did exactly the same survey among our breast specialists, and the majority, nearly 95% of medical oncologists want to give the combination dual inhibition.
But they can't because of reimbursement.
Exactly. And I think this is a problem in other countries.
So let me.
I asked, excuse me, I asked this question also to the breast cancer centers. I mean, it makes me very happy, but we have no reimbursement problem at the moment and for the last 12 months. So it's covered completely by the health insurance companies.